Order. Bobby Dean to move the motion.
Thank you, Mr Weston. It's a pleasure to serve under your chair. I'm grateful to have secured today's debate on NHS capital spending. This is a subject that goes right to the heart of how the NHS functions, and yet isn't discussed enough in this place. I had a look through some of the ministerial statements and questions in preparation for this debate, and I find that we often talk about staffing, specific illnesses, wait times and other operational performance issues. But the simple truth is that all of these challenges are made much more difficult to deal with until we improve the NHS buildings, equipment and technical infrastructure. And I get it, it feels much more impactful and immediate to talk about lifting nurses' pay or commissioning a new medicine. And these things are important. But however arduous the process, or however far beyond our electoral terms the output of capital investment may be, it is vital for the long-term healthcare of our constituents that we fight for these slow returners too. Happily give way.
I'm very grateful, and he's starting to make a very compelling point in his speech. In my local area, Stepping Hill Hospital has a reported repairs backlog of £138 million. What this means in practice is that only 4 of the 14 lifts are working. Staff are having to physically take up meals to patients, and those with any sort of mobility issue, family members with a mobility issue, can't visit their relatives on higher floors. Does he agree with me that, yes, we're talking about bricks and mortar and buildings, but we're also talking about people and patients and their quality of life?
I'm grateful for the point my honourable friend has made, and of course, as I get through my speech, I'll come to very similar points about maintenance backlogs and the impact that they're having. I believe it's partly because of the slow payoff of capital investment that we're in the mess we are in now. The last Conservative government completely undermined the NHS's future by over-promising, under-delivering and sacrificing long-term investment to plug holes in their mismanagement of the public finances. While capital underspends being plundered for revenue black holes is not a totally new innovation, it did accelerate under the Conservatives, where the most acute period saw more than £4 billion raided from the capital budget in the 5 years building up to 2019 to cover deficits in day-to-day spending. And I note that this was prior to the pandemic, where of course operational pressures were clearly stress-tested to the limits. And I have no doubt that this underinvestment left us more exposed than we otherwise would have been during this period. And the outfall is staggering. If we had simply matched existing levels of capital spend, more than £30 billion of additional capital would have flowed into the NHS. And instead, we watch buildings decay, equipment age, diagnostics fall behind, and maintenance backlogs soar. I will give way.
I thank my honourable friend for giving way. Medical devices and equipment are increasingly becoming pressure points as trusts are relying on ageing, life-expired kit. Now, my trust, Torbay and South Devon NHS Trust, have had fantastic results in bowel surgery from a free trial of a robotic surgery system that they were offered, but they now can't afford to buy the system because they have to replace other equipment which is on its last legs. So does my honourable friend agree with me that the Minister should set out how the government will ensure that NHS capital policy supports not just buildings and maintenance backlogs, but clinical equipment and the technology needed to deliver safe, high-quality, innovative care for patients?
My honourable friend makes an excellent point. This is not just about buildings, it's about equipment and digital and technical infrastructure as well. Absolutely crucial to getting the NHS to operate in the way it should. And she also highlights how ageing equipment needs to be just upgraded to the very basic level, let alone taking advantage of all the opportunities that new equipment could provide us with if we were able to purchase the very latest in innovations. So I mentioned the maintenance backlogs soaring. They've doubled from around £6 billion in 2015 to over £13 billion in 2024. And I think the critical thing to stress is that it did not have to be this way. The UK has invested around a third less in health capital during the 2010s than other comparable nations. And according to the OECD data, the UK has 10 CT scanners per 1,000 people, compared to an average of nearly 20 per 1,000 across Europe. We have 8.5 MRI scanners per 1,000, compared to an average of 12 per 1,000 across other EU nations. And our bed capacity is pitiful. We operate at around 2.4 per 1,000 people, compared to an OECD average of 4.4. And the issue hasn't only been a lack of money, it has also been a lack of certainty and flexibility. The approvals process for capital bids is slow and cumbersome. Even when capital is available, trusts often receive final sign-off so late in the year that they physically cannot begin procurement, get survey work done and start construction in time. And the money therefore goes unspent, not because of poor planning locally, but because the system itself creates delay. And I will give way, thank you.
Thank you very much for giving way. And just on that point there, one of the issues I have in my local authority is that it's currently sat on £50 million of developer funds which have been paid to the local authority, but those funds aren't being spent in the local community because there isn't the total money needed to be able to invest in health infrastructure, schools and other things. Would he agree with me that this is something that we have to look at to make sure that that money set aside by developers is being spent with urgency in our communities?
Yes, the Honourable Gentleman highlights the complexity in putting together large capital projects. You often don't get funding from one source, it's multiple sources, and therefore everybody providing that capital needs to have greater flexibility in order for the schemes to become deliverable. Otherwise they end up getting clawed back and put elsewhere, as they have been done in the past. The yearly cycle that I speak about is important because in the past, CDL rules, Treasury rules, have meant that any unspent capital must be returned to the Treasury at the year end. It not being able to carry forward punishes good financial management, prevents multi-year planning, and leaves trusts scrambling to spend money before deadlines rather than investing it strategically. The result is a system where underspends exist at the same time that there are record levels of urgent capital need, and trusts want to invest and start work, but the system ties their hands. Now, the effect of all this has not been abstract. The buildings maintenance backlog includes high-risk failures, operating theatres closed due to ventilation problems, leaks near electrical systems, sewage failures, and outdated wards where modern clinical standards simply cannot be delivered. And a 2022 BMA survey found that 43% of doctors reported that building conditions negatively impacted patient care.
Will my honourable friend give way on that point?
I will give way.
I thank my honourable friend for giving way. He's giving a powerful and important speech. Half the residents in North East Hampshire, my constituency, are served by Basingstoke Hospital, which was included in the now infamous 40 new hospitals by 2030 promise. Now it seems completion could be as late as 2046. This delay means another 20 years of spending taxpayers' money on a building with leaking windows, exposed wiring, an uninsulated roof, and countless other physical problems, and a bill that is going up and up every year to maintain this crumbling building. Does my honourable friend agree that asking taxpayers to pay twice is a waste of public money, and Basingstoke Hospital and others should have their rebuilds brought forward?
I do agree with my honourable friend, and I promise her I will come onto the new hospitals programme, as my constituency stands to benefit from it too, if it comes soon enough. And in the meantime, as you say, we are paying twice that sort of premium on paying for all the repairs and patchwork and never keeping up with the investment we need. Ageing diagnostic equipment also means fewer scans, longer waits and more delayed diagnosis. Last year, I had the pleasure of visiting my local hospital's nuclear medicine unit, and they showed me a new machine that was driving down diagnosis times from hours to minutes. And obviously this is a fantastic sign of good capital investment. But when I spoke to the Trust, I was shocked to discover that it's one of the only hospitals in the country with this particular piece of kit. And I just thought to myself, how much more productive the NHS would be if the equipment like this was rolled out routinely across the country as soon as it became available. And then, of course, there's the infamy of poor IT systems. More than 13.5 million clinical working hours are lost every year due to poor IT. And we've all heard those shocking stories of hospitals running on Windows operating systems that we were talking to a paperclip on 20 years ago. And in an age of AI, and AI is promising to sort of transform the workplace, it'd be great if the NHS could just catch up with the last decade or so. And speaking of AI, I did recently meet with an AI developer who thinks they've come up with a solution to the elective surgery booking system. His system auto-calls patients and offers them a choice of appointment, making hundreds of calls in just minutes. And they said that this beats the old system on two counts. The first is usually you receive a date without any choice at all, and it comes by post. But their trial in the Midlands saw that did not attend dropped by 50%, and they put that down to the fact that there was patient choice in the appointment time, and it was guaranteed that it was delivered to them because they picked up the phone and answered it. And again, just think of the potential productivity gains we could make if this sort of technology was picked up at scale. So if I've explained a little bit about the past state of NHS capital spending, it's now to turn to where the government has got to today. And the part of the point of me bringing this debate is to try and find out exactly where the government thinks it is. But it is worth saying that the stated intention of this government has been a step in the right direction. There has been more certainty, more money and more flexibility. And after the initial one-year capital settlement for 25-26, with some assurances that things would continue, the spending review did confirm capital budgets all the way through to 29-30. And these decisions will provide some stability, though it is still uncertain about whether the Treasury core black system remains in place on an annual basis or if it's going to be over the course of that spending review period. In terms of money, there was a substantial uplift in the year one allocations, but it is followed by a relatively flat commitment going forward, albeit, of course, at a higher level than previous due to that initial uplift. And I don't think we should be churlish about this. An increase in investment is inarguably good, but equally we should not kid ourselves that investment is now at the required level. It does not fully address the inadequacy of past investments, nor does it bring it in line with international comparators. And the King's Fund have described this failure to reverse the historic underfunding by the previous Conservative government as extremely disappointing. And the NHS Confederation are asking for the commitment over the spending period to be doubled in real terms, from 3.1 billion to 6.4 billion. There has also been some greater flexibility, with Treasury approval now only required for capital projects in excess of £300 million. This was previously a pitiful £50 million. And this new delegated authority will, of course, cut layers of bureaucracy out and speed up delivery on the ground for ward refurbishments and equipment purchases, though it will not address the issues inherent in the largest NHS capital schemes, which brings me on to the new hospitals programme. Now, this programme was imagined by former Prime Minister Boris Johnson, and I say imagined because that was the only place it really existed for some time in his imagination. And emblazoned on Conservative leaflets in my patch was a promise that the money had been secured for a new hospital building and it would be delivered by 2024. And I'm sure the same was true for many in this room. And of course 2024 came and hardly a brick was laid across the country. And when the new government come in, they told us there was never any money allocated for these schemes in the first place. The programme was then reset by the government with an updated timetable and revised waves for projects. And my local hospital's building was put into the second wave, meaning work won't begin until the 2030s. It was a bitter disappointment. And since that announcement delay, things have gone a little quiet overall. And so a year or so on from that announcement, people are now wondering how the programme is getting on. There are rumours that some in the first wave are not keeping pace and could be underspending their allocations already. Mostly this is put down to the adaptation period of the Hospital 2.0 model, an attempt to homogenise design across the country, which is broadly welcome. But any such delays will spark questions about what will happen to that allocated spend. And hospitals like mine will want to be right at the front of the queue for any reallocations if such an opportunity should arise. And I've mentioned my local hospital already, but St Helier Hospital, I don't think there's a case of capital neglect any clearer than the one in my own constituency. St Helier is as old as the NHS itself. It is overcrowded, cramped, and the specialist emergency care functions are simply not up to modern-day clinical standards. And let me be clear, staff at St Helier are working heroically, and patients are safe, but they are doing so in a building that is simply not designed for the 21st century emergency care. Patients are being routinely treated in corridors. Key recommendations for improving service delivery simply cannot be implemented because there is physically not enough space. And despite spending tens of millions on basic repairs in recent years, the building is deteriorating faster than the trust can fix it. Now, the new hospital programme promised to resolve many of these issues with a new building for emergency and maternity care. But with that delay well into the 2030s, residents in my constituency are left facing another decade of care in a building that is visibly past its lifespan. Yes, I will.
Thank you for giving way once more. I'm based on the outskirts of Nottingham, and already this year we've had 3 critical incidents at Queen's Medical Centre, which is the main hospital in the city. And that has all been based around A&E, and it's exactly the situation he describes. It has capacity for 350 patients, but it has been routinely seeing over 500 at a particular point in time. So would he agree with me that, in addition to the pressures that he describes, there is a reputational risk to the NHS when these types of incidents are being declared because of physical capacity issues?
I agree with the honourable gentleman, and I'm sure, like he hears constituents say that they don't want to attend the local A&E because they don't trust that they'll be seen in time. So I'm sure the figures that he's describing are an undercount of the people that probably should be in there. And like him, he would have been receiving emails about corridor care for some time, and I had hoped that corridor care was sort of this peak crisis moment and that it would subside, but it hasn't. It's become the norm, and that is extremely worrying. It's not acceptable for patients, it's not fair on staff, and it's not a sustainable way to run our NHS. If the government is to reconsider which schemes should be in which waves in the new hospital programme, then let me assure the Minister that my local trust is ready to go. Plans have been drawn up, land is secured, teams can move at pace. We need this, we want this, we are ready. But if that is not possible, but there still remains other pots of capital to be reallocated, then let me make a separate plea. Extend St Helier's emergency department now. This is a smaller ask than delivering a whole new building, but it will make a big difference. The only thing more full than the corridors at my local hospital right now is my inbox filling up with constituents describing their traumatic experience. St Helier Emergency Department sees around 250 patients per day, with routine overcrowding leading to the trust being placed into national oversight measures. And it means my constituent Kirsty was left anxious waiting for her mum of 83 years old to be seen, witnessing elderly patients crying, vomiting, screaming and walking around in severe pain in the corridors. And Mohammed, whose father-in-law waited over 13 hours only to return home without seeing a doctor at all. And others all have shared deeply personal details of their stories with me, and their condition was explained to them alongside countless others in the same corridor. It's undignified, it's unjust, and it's not safe. Now, the Trust have come up with a plan. They believe that they can redesign the existing estate, creating a new urgent treatment centre and expanding the same-day emergency care service, and doing so, they will dramatically increase the number of patients they can see. In the urgent treatment centre, they'll be able to handle up to 30% of patients, up from 14%, and in SDEC, they can get to 20%, up from 8%. And this will prevent unnecessary overnight stays, free up hospital beds, speed up ambulance transfers, and reduce delays for patients needing hospital admission. And it will also address £15 million of the Trust's ageing estates backlog. That plan is immediately deliverable. They believe that work can begin as early as autumn 2026, and it would make an incredible difference. And so I asked the Minister to make use of any influence they have on this matter to help the proposal get over the line. Now, before I conclude, I'd like to raise one further point about NHS capital expenditure that I suspect will not make me popular, but I believe is right, and so I will go on. The government has tentatively re-entered the world of public-private partnership models with its announcement of neighbourhood health centres late last year. Now, we all know how disastrous this model of financing was in the past. The long-term costs to the taxpayer far outweighed the short-term benefits. Britain was among the first in the world to pilot such a scheme, and it failed fast. But it must be said that other nations have learnt the lessons of our failures and successfully delivered social infrastructure at scale, on budget and on time. And indeed, I believe it is one of the reasons that we have fallen behind so badly. And as a Treasury Committee member, I recently guested on a Public Accounts Committee inquiry into PPP. And they concluded if we get procurement, contract management and the risk allocation of projects right, then we can massively accelerate the delivery of infrastructure in our country in a way that delivers real value for money for the taxpayer. I'm happy to give way.
Thank the Honourable Member for giving way and congratulate him on the debate. Just on the issue, which if I summarise him correctly, we need to better spend the monies that are currently being deployed in the NHS. Would he agree with me that that has to be the underpinning feature going forward as more and more money has been poured into the NHS? And we all think it's a fantastic organisation and praise those who work in it, but we need to spend it better and modernise the monolith that is the NHS.
Yeah, I agree with the honourable gentleman. I believe he's hitting on one of the central points of this debate. We can continue to pour money into the operational side of the NHS, but if we're not getting the capital expenditure right, if we're not improving the equipment, the systems, the buildings, then we're always going to be pouring good money into bad. Just to finish my point about PPP, I know that it is fraught with political risks, particularly for a Labour government who will be scarred by what happened in the past. But I do urge them to look at the report by the NAO, look at the experience of others internationally, and listen to the NHS Confederation, who are now pushing the government to go further and start to experiment on different financial models for delivering this infrastructure we need at scale. So, in conclusion, Mr Weston, NHS capital has been insufficient, uncertain and inflexible for far too long. The new government has good intentions on improving all three, but now is the first moment we can start to look at their delivery. And given what I have outlined today, I would now like to put several questions directly to the Minister. Can the Minister update us on the current level of NHS capital underspend under this government? Where in the system is that underspend occurring and what is being done about it? Will the government allow trusts to carry forward any unspent capital to future years? And would this exist beyond the current spending review period? What assessment has the department made of the new hospital programme delivery? And will any schemes be reconsidered for movement between the waves? And can the Minister outline whether the government plans to reform the capital allocation system to allow multi-year planning and reinvestment of trust surpluses permanently? The NHS cannot function without modern, safe and efficient infrastructure. No government can deliver improvements in performance or productivity without addressing this capital crisis at the heart of our system. I urge the Minister to use this moment to reset the capital regime, put it on a footing that prioritises long-term investment, accelerates delivery and gives patients and staff the facilities they need and deserve.
Minister Carrington.
Thank you, Mr Weston. It's a pleasure to serve under your chairmanship this morning. Can I first of all thank colleagues for their kind remarks about my colleague, the member for West Lancashire. We will miss her. I think she's done a great example, not only by continuing whilst undergoing cancer treatment, but also, as members have said, by taking that power to recognise that sometimes you do need to look after yourself and prioritise your constituents. And no doubt she will be doing that very well. I'm looking forward to her contributions from the backbenches. I can't tell you how much I am looking forward to that. And can I really congratulate the Honourable Member for Carshalton and Wallington for securing this important timely debate. I hope when he was perusing previous debates in this thing, my name came up occasionally, because I am one of the few members of Parliament over the last 10 years who, as I said, banged on quite a lot about capital. So absolutely delighted to be the member, because it is absolutely crucial. And the sound management of that capital is absolutely a crucial resource to the provision of healthcare for all our constituents. And I agree, it doesn't get enough airtime, and I think he made an excellent speech and contribution actually outlining most of the issues. And we've had a lot today. I'll try and do justice to a very wide-ranging debate. But I'm going to remind ourselves of the problem here. And my old friend, I brought Lord Darcy's report. It has been mentioned, but as he said, the NHS has been starved of capital, and the capital budget was repeatedly raided to plug holes in day-to-day spending. £4.3 billion lost in that way between 2014 and 2019. Crumbling buildings, services disrupted at 13 hospitals a day in 2022-23, and a backlog maintenance of more than £11 billion. And the NHS, as he described, in the foothills of the digital transformation that the rest of the country and the rest of the world was undergoing. Plus, the shortfall in capital investment. And I kind of admired the spokesperson for the Conservative Party opposite in his defence of that situation. It's a tough gig to do, and I think we can all see what happened in our constituencies. And I'm very proud of the investment in capital under the last Labour government, and I'll come back to PFI in a moment. Reversing this trend and repairing and building our healthcare estate is an absolutely vital ambition of our ambition to create an NHS fit for the future. And that is why we are prioritising the estate to support the task. First of all, prioritising core and safety, technology, equipment, changing the rules on capital. That's a really important measure that the Chancellor made to stop that capital revenue transfer, incentivising the system, streamlining the processes. The Honourable Gentleman tells us how terrible the processes were. They were in government. We have taken control. We have used government for good effect to start streamlining those processes. Part of that is about the movement towards making one team within NHS England Department of Health. I hope honourable members will support us in that. Building the capacity and the capability of the staff in order to develop and do the work that we need them to do, because that has been completely depleted over the last 14 years. We've put a lot of information into the system to move this and to move it quickly. I think we are all seeing the benefits of that in our constituency, and we will be bringing forward a capital plan in the spring to outline that and make all of that clearer, I think, both for the system and for honourable members. The charts, very briefly,
for giving way, and she's making an important point about the absolute vital need for capital funding in the NHS, and particularly for myself and a number of my honourable colleagues here, because we have a hospital, St Helier, that's obviously falling apart, and unfortunately patients are being affected, and we know that unfortunately the hospital programme has been delayed another 3 years. And I know there's been lots of goodwill here, and we're really looking for additional investment in the A&E, and I really hope that the Minister will take that away, and it might be something that might be forthcoming in the statement soon.
Thank you. I mean, the Chancellor has made her key decision to put us back on track, announcing in the budget previously capital health spending increasing by 15.2 billion by the end of the spending review in 2029-30. This funding will be used as intended. In previous years, as we've heard, the capital funding was diverted to cover those day-to-day costs. We have tightened those Treasury rules. We have changed them. That's what government can do. Who knew? And as a result of that, capital funding will now be fully focused on repairing, upgrading and expanding NHS buildings and facilities to support long-term productivity. This settlement represents record levels of capital investment into healthcare, and it will support the 3 shifts set out in the 10-year health plan, moving care out of hospitals into the community, replacing outdated systems with modern digital services, and focusing on treating illness, preventing illness rather than just treating it. Of course, rebuilding NHS infrastructure cannot happen overnight, and I can assure honourable members here today the government does understand that long-term certainty over capital funding is needed for the NHS to move from these short-term fixes to more strategic investment, and that's another key decision made by the Chancellor. That's why we've delivered a 4-year capital health settlement extending to 2029-30 through the 2025 spending review, backed by a further 5 years of certainty for estates maintenance and funding. And I genuinely grateful to honourable members for recognising that that is an absolutely massive change for the system that we have engineered into it. And I think we are all seeing the benefit of that. It does mean £30 billion commitment in capital funding over 5 years to support the day-to-day maintenance and repair of the estate, with a further 5 years of funding certainty as set out in the 10-year plan. For the first time, NHS trusts have also been given multi-year operational capital allocations with clear funding set out to 2029-30 and indicative funding for a further 5 years. This is an unprecedented opportunity for local health systems to plan with confidence over a 9-year period, and I continue to encourage all members to engage with their ICBs who will be prioritising these schemes over that period. Within the £30 billion, the Estate Safety Fund will continue, providing £6.75 billion investment over the next 9 years to target the most critical building repairs, alongside £2 billion to continue supporting NHS England's National RAC programme across the spending review. Additionally, £21 billion in operational capital over the 5-year spending review will empower NHS organisations to invest in local priorities, including hospital infrastructure. It will take time. Building up the capacity as well as the capability will take that time, but this does mark the beginning of our rebuilding that NHS fit for the future. Now, I would also like to assure members here that this government recognises the pressures faced across the system and bringing back performance standards to what patients expect. And that is why we're investing to expand hospital and emergency care capacity, helping to reduce waiting time and improve care for patients. So over the next 4 years, there is the £1.9 billion for urgent emergency care to support A&E departments and support ambulance services in reducing handover times. 1.5 billion for diagnostics, including funding to expand and build on the hours of particularly community diagnostic centres to shift care from hospital to the community. The Honourable Gentleman noted that they were started under the last government, of course, but we have made sure that they have expanded times, expanded hours, that there are more of them. And crucially, they're not built as add-ons, but they are fundamental to the pathways experienced by patients in this system and make sure that we have good value for taxpayers' money. 473 million for mental health services, including for people with learning disabilities and autism. I think we'd all agree that the mental health estate also needs recognition here. Over 280 million for community care supporting services closer to home, and over 139 million for electives across the next 2 years. Moving away from paper-based systems and towards a modern digital services, the autumn budget confirmed 300 million capital investment in technology, building on the combined revenue and capital investment of up to 10 billion by 2028-29 announced at the spending review. We are transforming healthcare by shifting care out of hospitals and into the community, and over the next 4 years we are investing more than 400 million into upgrade primary care buildings and deliver neighbourhood health centres as part of our commitment to those 250 neighbourhood health centres through the rebuild programme. I'm going to just finish these points, if I may, and answer some of those issues. The first 120 neighbourhood health centres will be operational by 2030 and will, as we've heard, be delivered through a mixture of public and private partnerships. And I thank the Honourable Member for Carshalton and Wallington by being one of the few who have acknowledged that this is difficult. There's some controversy around that, but I'm a very strong supporter of the previous LIFT schemes. And I'm a very strong supporter of my own scheme, Southmead Hospital, which is one of the better PFI schemes that delivered unprecedented levels of care, including to myself, for the people of Bristol. It is important that we learn the lessons of the past, and we absolutely have, including the NAO report, and absolutely, working with NISTA, as has been outlined, we will continue to pursue that and bring forward those cases. I don't want to re-rehearse the lack of funding, really, for the new hospital programme. I'm not going to give way in this. I'm going to get through my final comments. We did put it on a sustainable footing. I do understand for local people across the country in different areas, they have been led up a garden path, frankly, and told something was going to happen, and the money was not there. I think we all recognise that. It wasn't on that sustainable footing, but we have done that. We have backed it with the appropriate investment, rising to £15 billion over each consecutive 5-year wave from 2020-30, averaging £3 billion a year. The exact profiles of funding will be confirmed at future spending reviews, and of course it is weighted in order to make sure that we recognise at the time that schemes come on profiled most are absolutely caught up in that. We're progressing wave 1, and I will continue to liaise with honourable members about the progress. My message every week to any NHS trust, any Member of Parliament, to NHS England, to the team running the new hospital programme is we need to deliver them. There is a large queue behind these hospitals. We've heard about some of those again today, Mr Weston, and there is also a number of colleagues who don't have a hospital being progressed in this scheme. I understand that, and the government wants to build these. We are very keen to get on, and as honourable members have said, a lot of this is about trust and commitment. So I want members here to be very clear, and anyone paying attention, that I am very clear. It is important that we get on with this programme, that we deliver on the ground, and we make sure that it is robust. Finally, alongside increased capital funding, we are improving how that funding was measured. As we've heard, the old processes did not work. Local schemes going to an ICB, to the region, to NHS England, to the department, to the Treasury and back again. Huge amounts of sign-off, no control, no accountability, and no one locally understood what was happening. We are transforming that. We are bringing together the team. We are streamlining that process, making sure it is, of course, well governed. And that will make sure that things are happening quickly. And we are already seeing that, so that the overspends, underspends this year, we've got money out, we've got them into schemes that are already into the system, we've improved getting more DEXA scanners. That is how we make sure that this actually happens on the ground. It is up to ICBs to prioritise proposals. We are working more closely with them to support them to bring things forward. And I really do urge all members who have spoken today, my friend from Harrow West, from Torbay, from Rushcliffe, Taunton and Wellington, Sutton and Cheam, Eastbourne, North Devon, on particular schemes, keep working with your local system, but I'm very happy to keep talking to people. To the member for Taunton Wellington, I have met with NHS England about that proposal, looking at maternity in the area. I know it's a huge concern. I'm very happy to meet with him. I will get back to the member for North Devon about some of those numbers that he's outlined. They are not familiar to me, but to the other point that was made, we are making sure that we are building in contingency for the future, because we obviously know we live in volatile times. Thank you very much.
Proceedings are finished. We move on to the next debate.